So as women were kind of excluded from medical trials, we knew less and less about how medicine actually affected women. Instead, the FDA was kind of like, you know what, women are basically like slightly weird men. Like in essence, right? Like there are some like slight physical differences. Some of them are internal, so basically it's like they're not there. But like women are like defective men, and the bits of them that are different are like mostly their own fault. So we can just study men and then tell women stuff about that, and then that will mostly work for medicine. So in an article in Slate, Melinda Wenner-Moyer reported that there are real disparities in how men and women respond to medical interventions. And the less we include women in studies, the less we know about what we're actually doing. She writes, women taking antidepressants and antipsychotics tend to have higher drug concentrations in their blood than men do. They also require half as much influenza vaccine for the same level of protection, though they are always given the same amount. In an analysis of 163 new drug applications submitted to the Food and Drug Administration between 1995 and 2000 that included a sex analysis, drug concentrations in blood and tissues for men and women in 11 of the drugs varied by as much as 40%. However, the applications include no sex-based dosage recommendations. Finally, women are more likely than men to experience adverse drug reactions. 8 of the 10 prescription drugs pulled from the US market from 1997 to 2001 caused more side effects in women. And that's really not surprising, because if it's primarily men in the pipeline for testing drugs, of course, the drugs that have adverse effects on men are more likely to be caught earlier in that process, in those phase 1 and phase 2 trials. And women will wind up finding out about these consequences when their doctor prescribes them to them. They'll find out about these consequences when no one's still keeping track of the effects drugs have for the patients who are taking them, and it's just you talking to your doctor saying, this made me feel really sick, and they go, well, it was fine in the trials. Like, it's a problem with you. Statistically, the drug is fine. It's a problem with you. Now, the FDA lifted its restrictions, but even after the rule was rolled back, women were still dramatically underrepresented in clinical trials. Pretty much any marginalized person you can think of, women, African Americans, Native Americans, always are underrepresented in clinical trials. We always know less about how drugs influence anyone who is not a white man. But one of the reasons that scientists still seek to exclude women is because they're worried that women will mess up the results. And the cause of why they're excluded is, quote, the irregularities of the menstrual cycle. Because since a woman kind of goes through relatively large hormone swings over the course of the menstrual cycle, rising estrogen, rising progesterone in the second half, scientists are like, gosh, guys, this is hard. Like, this is hard. Like, I don't know how estrogen interacts with this drug, and I don't want to figure this out. And in fairness, as a statistician, because much of statistics is like, oh goodness, that is hard to sort out, right? One of the problems is you start a drug trial, you have women at various points in their menstrual cycles who are all having different kinds of interaction with the drug. Even if you're giving a drug over kind of a month regimen, you're kind of catching women at all different points with all different levels of different drugs, essentially, in their blood interacting. And the scientists are like, oh. First of all, I have to enroll 1 million women, just to figure out what's going wrong. And now I have to segment them out by where they are in their menstruation. This is a mess. I'm going to enroll in instead. Or in some cases, if you have a very short study, you enroll women immediately after they get their period, so they're in the first phase of their menstrual cycle, when a number of the hormones are lower and just more similar across the whole group. And you're like, I have found out how this drug works in women for approximately 2 to 4 weeks. Then there's another 2 weeks, and it's just anybody's guess, but for 2 to 4 weeks we know what we're doing. We see story after story, and woman after woman coming forward to talk about how her own experience in her own body was ignored or treated as the problem, rather than the lack of knowledge we have about women being the problem. For me, this started in high school. Because I, when checking with my doctor, was told I had longer and irregular cycles, was screened for polycystic ovary syndrome, and the doctor just kind of went, okay, so you can take the pill. I hadn't asked for a solution to this problem to begin with, but from my doctor's point of view, the problem was my cycles didn't match the model, and the pill would cause that problem, from her perspective, to go away. It would take the complexities of my body and round them down to a nice matching the textbook model externally. Because of course the pill wouldn't do anything about my PCOS, wouldn't check to see if there was a cause for it, wouldn't check to see if it had downstream effects that could affect my health or my fertility. It would just make my body think it was pregnant most of the time, but give the phenotypical appearance of a normal cycle, which would be enough for my doctor to go check, normality restored. In some ways, medicine kind of treats many patients, and especially women, as though the correct solution is a Procrustean solution. Because Procrustes of Greek mythology was a legendarily terrible host who wanted his guests to all be suited to their beds. He didn't have beds of various sizes, to be clear. He had one bed, and if you were too small for the bed, he stretched you out till you fit. And if you were too long for the bed, he just cut off whichever bits hung off. And through this, a perfect clinical textbook success, where everything fit the model. It was only when I learned NFP in preparation for marriage that I was encountering a form of medicine that actually had to do with me, and not to do with a model that I was expected to aggressively reconform my body to the appearance of, regardless of what was actually going on internally. NFP is a model of medicine that kind of treats each woman individually by observing her particular cycle and kind of tailoring any intervention, if necessary at all, to her body. And it wasn't until I learned NFP that I got the slightest indication that actually mostly everything in my body was going fine, which wasn't something my doctor had checked. My cycles were long, but everything that was supposed to happen was happening, which was not something that my doctor had seen it as her business to check, just to regularize the length regardless of what was going on. And it certainly wasn't something the pill was going to help treat. And this isn't just my story, it's woman after woman's story in area after area of medicine. In her book, Conceivability, What I Learned Exploring the Frontiers of Fertility, Elizabeth Katkin reports her own experience of doctors taking this sledgehammer-like approach. How will I solve this problem as definitively as possible, according to what I can measure most easily, regardless of how that impacts you and your health? Elizabeth Katkin was seeking out fertility treatments, including IVF, and went to doctors who kind of gave her the highest possible doses of fertility medicine because she was older. And they said, what you need is as many eggs as possible. And it wasn't until later, as she kept kind of exploring her options and visiting different doctors, that she found out that kind of this, all-in approach, without kind of attention to her own body, attention to the range of dosing suggestions, had produced a lot of eggs of very low quality, in ways that made it harder for her to ovulate in any other way, and put her at greater risk, though of course it's always hard to tell whether this is the cause of the miscarriages she suffered while doing IVF. And later she found a different doctor who was interested in lower dose hormones because their goal wasn't, all right, well, eggs are our outcome, how do we maximize eggs? And saying, pregnancy is our outcome, your health is our outcome. It's messier. We won't always know exactly what we're doing, but we're not going to cling to the one thing we can measure confidently and let that eclipse everything else. We won't cling to eggs, cycle length, as the sole measure of what a woman is, and then everything else goes by the wayside. And in another book and another kind of personal story, Abby Norman, the author of Ask Me About My Uterus, a quest to make doctors believe in women's pain, talked about the cost of sidelining women and their experiences of their own bodies. And she wrote, although a male physician could quite easily and convincingly assert that ovarian cancer was silent, if you were really to listen to women who have had ovarian cancer, you'd find it wasn't so much that the disease process was silent, but that they were. Conditions that seem to lurk unnoticed in a woman's body go unnoticed by others, because for one thing, They are an assumed part of womanhood. And for another, women are taught to keep those pains private. Where she talks about the story of woman after woman with ovarian cancer, with endometriosis, who would come into a doctor and talk about, that their body had gone through changes, kind of, they were already tracking in the way NFP encourages you to know your own body, to know your own baseline. So that instead of relying on the average model, you know when something's going wrong for yourself, and then you can bring in the resources of where science can take you, but you're the first responder. And they would go to the doctor and say, I'm in so much pain during my period. This doesn't seem like it can be normal. The doctor goes, that's what happens to women. Women are just in a bunch of pain. Something feels wrong, women's bodies just go through a lot of changes, And in many cases, it was only when they'd show up with their boyfriends or their husbands and go, the amount of pain I'm in is interfering with sex for my husband, the doctors would take it seriously. If it interfered with sex for the woman, that was kind of negligible. Oh, sex can be uncomfortable. But the moment it interfered with sex for their husbands, that was when the doctor goes, this is something we have to take a closer look at. Maya Dusenberry recounts similar stories in Doing Harm, the truth about how bad medicine and lazy science leave women dismissed, misdiagnosed, and sick. But it shouldn't be unreasonable to expect that during this period of uncertainty, the benefit of the doubt be given to the patient. The default assumption be that their symptoms are real, their description of what they are feeling in their bodies be believed, and if it is medically unexplained, the burden is on medicine to explain it. Such basic trust has been denied to women for far too long. And I think as pro-life activists, we can feel like the burden isn't necessarily on us. We weren't the doctor telling a woman that her pain was irrelevant, that her symptoms were in her own head, that basically her whole body was not hers and not relevant to her, that it needed someone else to interpret it to her. But the fact is we live in a country and a culture where women have their own connection to their bodies erased again and again. And that means part of our burden is the burden of healing that gap. And really arguing what this hazard did, which is that the more we're connected to our own bodies and the truth of them, the easier it is to argue for the pro-life position. But there are real wounds that women have already experienced before they're ever facing the choice of how am I going to think about the relationship of this baby to my body? And that women, have been trained to correctly be suspicious of anyone who's arguing with them about their own experience of their body. I think our opportunity is to kind of find ways to tell a broader range of stories, to go, neither is a woman nor a doctor the only or perfect interpreter of what's happening, but there's a tremendous disconnect, and it keeps harming women. And everywhere we can try and heal that wound and close that gap, we're working for it. Abortion is one of those places, but not in the way you expect. Now, in my own case, during my third miscarriage, my doctor managed to neglect both me and my baby in her approach to treatment. My blood tests and my ultrasounds indicated that our baby was probably ectopic, that our baby was in the fallopian tubes, probably, with no chance of being born and some chance of threatening my own life. And my doctor told me that as the doctor, the expert, the only responsible option was for me to leave the ultrasound place I had gone to and go directly to the hospital to get a methotrexate shot. Methotrexate is a chemotherapy drug, and you might wonder why that's what was being offered to me, since what I didn't have was cancer. When you're pregnant yourself, when you get her those little updates every week, your baby is the size of a poppy seed, your baby is the size of an apple seed, your baby is a sweet pea. Your baby is growing faster and faster. Methotrexate is a chemo drug because it targets cells in your body that are growing quicker than normal human adult cells do. Usually it's used for cancer. But it's recommended in ectopic pregnancies because the only other thing that's growing so fast in your body is a baby. The exact mechanism of action isn't quite clear, but it targets those cells and either dissolves the baby or dissolves its connection to the fallopian tubes. And again, we're kind of in the limits of what science can directly observe there. But this was definitely not what I wanted. Not as a Catholic, and not as a statistician, who kind of, with my own experiences, of doctors not telling the whole truth and finding the simplest, most definitive solution to a problem, regardless of what a patient wanted, had been staying up late while dealing with this frightening pregnancy, doing my own literature reviews. And what I knew that my doctor hadn't told me is that, based on my own hormone levels and how far were along in the pregnancy, a lot of women in my position wound up miscarrying naturally, without any need for medical intervention, without kind of any one acute scary moment where my life would be clearly in danger. And that for the most part, there'd be, as long as we kept up with blood tests, enough warning if things got more serious to consider what our range of options would be. And what I wanted was just to keep waiting, keep monitoring, and to give my baby, if not a chance to live, a chance to die in God's own time. My doctor hated this idea. For her, methotrexate was safe because it was a sledgehammer. We wouldn't have to keep up a vigil. We wouldn't have to keep wondering exactly what's going on. She wouldn't have to still be on call to figure out. Methotrexate would reduce my complicated situation to a simpler problem. Sort of. Technically, I would still need the exact same blood tests I was going to have with watchful waiting, because methotrexate works most of the time, but a significant chunk, around 20 to 30% of women, need a second shot because the first one doesn't cause them to miscarry. The effects would linger for 3 months, during which time I'd have to avoid pregnancy because the chemo drugs would still be in my system and would harm any new baby we conceived. Those drugs would still just be prowling through my body, searching like a lion for someone to devour. But that would only be my problem, not my doctor's. She would have finished treating my problem and would be done, and I would check me off as a successful patient, letting me be a solved problem instead of looking at either me or my baby as a full person. I refused treatment, kept up the blood tests, and my husband and I were able to say goodbye to our baby in God's own time. And what would the alternative to this look like? Where can we go for positive examples of what doctors can reach for as their model, for centering both the woman and the child, for using the real benefits of scientific research to inform their practice, but recognizing the limits of it so they don't wind up almost resenting the patient for not conforming closely enough to the model of the textbook or the study. I was really touched by just one other story from actress Carrie Coon in a profile of her by Michael Schulman in The New Yorker. Coon was pregnant during the period she was being interviewed by Schulman. And while the reporter was following around, she explained that she'd received frightening news about her pregnancy. Schulman writes, "A blood test revealed she had been exposed to cytomegalovirus, or CMV, a common virus, often spread by small children, that can have drastic consequences if a woman contracts it for the first time while she is pregnant. Amniocentesis showed her that the fetus was also infected. The doctors informed her there was a 10% chance of birth defects, including brain damage or microcephaly, and a 25% chance of serious hearing loss. But there would be no way of knowing if the baby would be affected until the birth. She and Letts were advised that termination was an option." We sat with that, just to see what it would feel like, Kuhn recalled, walking along the path. She considers herself a recovering Catholic, and her father's family is vocally anti-abortion. But that wasn't the issue. Quote, "He was already so much a person, and so much a part of our lives, that we couldn't really contemplate that," she said. She began thinking of her unborn child as a protagonist facing an obstacle. Suddenly there's a person with a struggle going on. The story of his life became very tangible for us. And what Carrie says there at the end is what I see as the model for doctors, for pro-life advocates, for anyone facing the confusion or the fear of a medical complication or question. Kuhn resists the idea to see her baby as an abstraction or as a medical problem, to round her baby down to a less complicated kind of story. She sees her baby as the protagonist, and that the pain itself is what reveals personality. Suddenly there's a person with a struggle going on. The story of his life became very tangible for us. One of my favorite moments of being pregnant with Blaze during that pregnancy came in the middle of this kind of specific trouble. During one of the ultrasounds my doctor sent me for, the goal was to confirm that the pregnancy was ectopic. And the ultrasound technician, was getting ready, and I told the ultrasound tech, that if she was able to find my baby, I wanted to see the picture. In our first pregnancy, although we'd had ultrasounds, the doctor never saved any of the photos of our baby Robin, and we don't have any physical memento of that pregnancy. And part of the reason is that they kind of round down to their best guess at what your feelings might be. It's a miscarriage, we can't take the risk of making it too real for the patient. And never asked me, do you want a photo of your baby? So I knew this might not be the choice every woman facing a diagnosis of an ectopic pregnancy had, which is why I wanted to speak up and tell the technician, I know this might mostly be something people feel sad about, but if you see the baby, I want to see the baby. And as it happened, our technician couldn't find Blaze at all. Not in the womb, not in the fallopian tube, not anywhere. And she told me it was possible the baby was just too small to see. Back to that problem of at what point the baby is visible to our technology. But she also said that what I had at that point, once the ultrasound wasn't good enough, was technically not an ectopic pregnancy, but a pregnancy of unknown location, which is usually abbreviated PUL, so that you don't have to lean so hard on the fact that the doctor has no idea where the baby is. And she kind of just said to unpack that for me, the baby could kind of be anywhere. Like usually when a baby isn't in the uterus, they're in the fallopian tubes, but the baby could attach to the spleen. And I've cried a lot in ultrasound rooms, but this is the only time when I had to stifle a laugh because I thought it would frighten the technician. Because the thing that was rising up in me to say that I just barely managed to bite back was, my baby could be anywhere. My baby could be right behind you. I've been pregnant 4 times in 2 years of being married, and I have no living children. And each of my babies has to be remembered by something that isn't their first steps or their first words or anything else. And Blaze is the baby who shared that joke with me in the ultrasound room. Really the only other person who was in a position to appreciate it at that moment. In the middle of death, there's still room for what Ms. Kuhn said. There's a person with a struggle going on, and the story of life becomes very tangible for us. I think our challenge is, in pregnancy and in every medical arena, to let each person's struggles and each person's wounds be an invitation in all their particularity more deeply. Thank you.
Any questions?
Thank you. So you have a room full with many students here, some of whom I'm sure are going into the legal profession or the medical profession, and hopefully bringing their pro-life convictions with them. What kind of advice would you give to these people about addressing the sort of problems you discussed? How can people who are hoping to be doctors, hoping to be advocates in some way for women and children, address the way women's experiences are made invisible in the current medical establishment and the current cultural conversation?
Statisticians who are most careful about how they use numbers. And it's everyone who cites us who goes way beyond what we actually think is appropriate. Because the rule is what isn't measured doesn't matter. And a lot of the time to be an advocate, the first thing you're advocating for is measuring all the outcomes that matter. And not just whatever is easiest to measure. In statistics, we call this the streetlight effect, right? Where you find a drunk person who's lost their keys and is just looking under the streetlight because that's where the light is, and they can't find them anywhere else, wherever they happen to be. And I think we see this just in the way women are cared for. Again, particularly in abortion, but in every single medical place. We see this in the way that women with postpartum depression are neglected also. babies' APGAR scores get tested. Women's like level of depression is hard to measure. Like, who can be bothered to sort this out? It takes interviews, it takes knowing the patient. That's hard. And again, in our own experience, the number of things my doctor never asked about was flooring to me. You know, I got plenty of questions about like rates of bleeding, hormone levels, so many blood tests. My doctor never asked me once how I was feeling, never screened me to see where the difference between grief and depression might lie. I know maybe she had the benefit there that she was seeing me at repeated appointments and was just kind of coming to her own best conclusion, though personally, I would not have trusted this doctor to have like a strong understanding of my own personal situation, especially because, like many women, I felt like I had to be careful about how much emotion I ever showed to my doctor, because every time I was upset would undercut my credibility to advocate for myself and give her more room to dismiss me as hysterical. But my doctor didn't keep seeing my husband at follow-up appointments either. So one of the other things that was just never measured is, how is this miscarriage affecting the father? There was no doctor involved who took the slightest moment to so much as ask casually about how my husband was doing, because he was not medically relevant to the problem they were solving, which is just, let's make sure there's no sepsis. All right, good, we're set. So I think that challenge to look for the whole story and to ask, what are the parts of this person's life that are by default or by design invisible to me? And really seek out those experiences. I think it's really striking that last year's VITA keynote speaker, Abby Johnson, while still working at Planned Parenthood, started steering women away from medication abortion because she'd had one. And it was her experience of having one. And a medication abortion doesn't take place at the doctor's office. So everything about a woman's suffering and pain is by default invisible to the doctor and kind of impossible for them to base their recommendations on. And what changed Abby's mind was the experience of having it. And suddenly, the clinical description of what women would experience was obviously false to her. The other doctors weren't lying, but they didn't have that direct knowledge, and nothing encouraged them to seek it out. So I think look for the ways people's stories are being rounded down, and ask both as a matter of process, how that data can be recaptured, and as a matter of personal responsibility, how you can ask people to share this with you so that you can know the full truth and not just what's most easy to measure.
I think there's a great injustice in the modern women's health sphere where with a lot of drugs such as certain vaccinations or birth control are two that come to mind, they're being tested on the general public and haven't had a clinical trial long enough to determine the long-term effects, which I think the feminist movement has a good place to get behind. So how do we change the dialogue to advocate for women's rights in that sense?
Always a balancing act, and the more space we give people to talk about the trade-offs and uncertainty they experience, the more room we have the full truth and come to a clearer understanding. Right? Because every year the flu vaccine is essentially being tested for the first time because it's a new set of strains of flus. And if we tested them like slowly and carefully, by the time we were certain they worked well, we'd be like 6 years past this year's flu and it wouldn't do anything anyway. So I think part of the challenge is kind of giving people room to go, here's what we know, here's what we don't know. How do I create the trust so that someone can talk frankly about what is uncertain without their next expectation being, oh, the moment I admit weakness, you're going to drive a Mack truck at me, right? And I'm someone who hasn't always been pro-life, and I think there's a defensiveness in these conversations where when people concede anything, they're afraid you'll make them concede everything. And it makes it harder to look at the bits of uncertainty anyone has. If they're afraid saying, yeah, you know, I guess I don't know exactly when life begins. And they're frightened to say it out loud because they feel like they'll be bludgeoned next. So how do you make room for someone to go, I have mixed feelings, like, can I have a little space for those mixed feelings without feeling like the next thing is, oh, so you've admitted you're wrong and a liar, right? And again, even if this isn't your own approach, people both imagine what's going to happen next or may have really had that experience. This is my own experience talking about my conversion to Catholicism too, that everyone I've spoken to about Catholicism, I assume, has had a bad conversation about Catholicism in the past. It may not have been me they had it with, but I don't get to go, you have to treat me as though you've never had these conversations before and give me the complete benefit of the doubt. Because that's crazy. No one reacts that way when they've had difficult experiences before. So I think the challenge is, how do we make room for people to be uncertain without that implying that they're liars and without demanding they pretend to a higher level of certainty than is reasonable?
Hi, thank you so much for your talk. I'm no longer in my childbearing years, but when I was, I ended up having 4 children. Their ages 21 to 28 now. 3 of them are daughters. And so my oldest, who is married, would like to have a baby. And when I think back during my childbearing years, and the hormonal issues that I was having, I remember walking into my OB-GYN's office. We had a piece of paper with my pencil and my stickers and my little thermometer, right? So I would do my stickers, and I remember him saying, well, you have some kind of hormonal issue, and they called it unexplained vaginal bleeding. And I'm like, no, it's explained. Look, you see my temperature? It's way down here. I need progesterone. I can explain this. And he looked at me like I had 2 heads. And I don't know if it's like that now, but I'm imagining it probably is. And I'm wondering, as a young woman, how should I advise my daughters on how to speak to their OB-GYN about how to guide them or introduce them or test them or whatever in their desire to have children, in a way that, you know, as an attorney, I might have come across too strong and threatened him with my vaccinated exhibits. So what would be a good way for young women these days to approach that? Because I would like to be a grandmother one day.
I mean, I think part of the challenge is that you just have to visit several doctors till you find someone who treats you like a person. And I have not found a way to convince doctors who aren't doing that to do that. During my first pregnancy, just when I was calling OBGYNs in New York, the first one I called, went, oh, we can't take you, we're all booked up for deliveries in November already. And I'm like, first of all, like, I just tested, like, I know the New York, like, preschool arrangement is insane, but how is it ever it has their deliveries booked before, like, they found out you're pregnant? And they're like, no, we're full. And I'm like, well, that's lucky, because I'm not going to deliver in November. Like, I have unusually long cycles, I can date ovulation, like, I'm doing December. And they go, when was your last menstrual period? I'm like, I can tell you that, but it's not going to help you date my pregnancy. And they're like, you'd have to speak to someone else in our office, but I don't know who that would be. And they just, like, gave up at that stage. And, like, my first instinct was to fight them. I'm sure it was not a great idea to, like, really fight to become a patient from a doctor who was, like, ignoring me at the very first step. So I'll mention, like, the better doctor I found for anyone in New York. For kind of the issues my husband and I have had around miscarriages, I've seen a doctor at the Gianna Center in New York, who is really excellent and is kind of open to exploring everything and really has the virtue of being honest about what she doesn't know. Where, like, we've had a number of conversations that aren't like the ones I've had with other doctors. She goes, this has sometimes been suggested in trials, like, it's not clear whether it definitely works or whether it will work for you. The side effects are minimal, so my recommendation would be to try this without us being sure it's even helpful, like, to anyone, let alone to you. And, like, having that actually unpacked is kind of the most helpful thing for me. But I think, it's a little bit that when someone tells you who they are, listen to them. Like, a doctor who's dismissing your concerns at your physical, even before you're having a problem, is not a doctor who's going to take care of you when you're in a more vulnerable position. And if you can find a way to talk more frankly to the doctor, to a nurse, like to someone, so you can communicate why you're leaving or why you're thinking of leaving, see if there's a way to do that. Because that way the doctor also has the opportunity to learn. When a patient disappears, that's the kind of data that isn't visible to them again, right? Where they go, oh, maybe they moved. Like, not maybe the way I treated them through